Okay, so we're going to jump ahead and start reviewing Chapter 3, Drug Interactions. Alright, so types of drug interactions. This is all in our review book. Continuing education topics. Okay, so types of drug interactions, pharmacodynamic drug interactions. Pharmacodynamics refers to the effect or change that a drug has on the body or some other type of organism. See study tip gal below. A pharmacodynamic, which is PD, drug interaction occurs when two or more drugs are given together and their end effects impact each other. Pharmacodynamics, pharmaco refers to drug, dynamic refers to an activity, such as a type of process or change. So pharmacodynamics equals the effect that a drug has on the body. The effect can be therapeutic. For example, morphine provides pain relief when it binds to the mu receptor. It could also be toxic. So excessive morphine could kill someone. So pharmacodynamic drug interactions can occur when two or more drugs are given together. The effects can be additive, such as they could produce more sedation. They could be antagonistic. One drug could block the effect of the other drug. They could be synergistic. So instead of 1 + 1 = 2, it could be like 1 + 1 = 3 or 4. They could have an amplified effect. Alright, so additive effects. Agonists binding to the same receptor. Multiple drugs that are agonists at the same receptor can cause additive effects. Example, opioids are mu receptor agonists, providing analgesia, but with a risk of fatal toxicity when overdosed. If two opioids, for example, morphine and oxycodone, are taken together, the effects would be additive with increased side effects. For example, excessive sedation, respiratory depression, and death. Additive effects, agonists binding to different receptors. Drugs that have similar end effects through different mechanisms/receptors can have additive effects. Example, benzodiazepines are sedating and can suppress respiration. The effects are similar to opioids but caused by a different mechanism. Benzodiazepines bind to and enhance the effects of the endogenous inhibitory neurotransmitter gamma aminobutyric acid, GABA, causing anxiolytic, hypnotic, anticonvulsant, and muscle relaxant effects, including relaxing the diaphragm, which is how respiration becomes suppressed. When taken concurrently with opioids, the additive effects increase the risk of a fatal overdose. Drugs in both classes have a boxed warning about this risk. See study tip gal below. So here's our warning. So risk with concurrent use of benzodiazepine with opioids. Due to the heightened fatality risk when opioids and benzos are taken together, the FDA added a box warning to all drugs in both classes. Warning: risks from concomitant use with opioids. Concomitant use of benzos with opioids may result in profound sedation, respiratory depression, coma, and death. Limit concomitant prescribing of these drugs to patients for whom alternative treatment options are inadequate. Restrict dosage and durations to the minimum required. Monitor patients for signs and symptoms of respiratory depression and sedation. Another example, warfarin causes anticoagulation through inhibition of vitamin K-dependent clotting factors. Aspirin blocks the effects of platelets. Although they work through different mechanisms, both can cause increased bleeding, and when used together, the risk is greater. Okay, so moving on. Antagonists block the action of agonists. An antagonist blocks the agonist from binding to its receptor. The agonist is unable to initiate a change that would have resulted in some effect. For example, analgesia from an opioid or respiratory depression when the opioid dose is excessive. For example, naloxone is a mu receptor antagonist. It saturates mu receptors and blocks the opioid from binding. Naloxone is used to reverse respiratory depression, but will also reverse the analgesia effect. All right, now we're going to look at the synergistic effects. Synergism is present when two drugs taken in combo have a greater effect than that obtained by simply just adding the two individual effects together. So for example, if you give a patient some oxy, that will provide analgesia as a mu receptor agonist. Tylenol provides analgesia by a different mechanism, which is not fully understood. Some of the analgesic effect is thought to occur via inhibition of prostaglandin synthesis in the central nervous system. The mechanisms that produce analgesia with opioids and Tylenol don't overlap. Tylenol taken with oxy produces more analgesia than the effect that would be expected from adding together the analgesic effects provided by each drug. All right. Now we're moving into the topic of pharmacokinetic drug interactions. Pharmacokinetics, or PK, refers to the effect or change that the body has on a drug. See study tip gal below. Pharmacokinetics. All right, let's define it. So pharmaco refers to a drug. Kinetics refers to motion. Therefore, pharmacokinetics equals the effects that the body has on the drug as it goes through the absorption, distribution, metabolism, and excretion, or ADME processes. All right, let's define those. Absorption typically occurs in the small intestine with oral drugs. Distribution through the blood and dispersed throughout the tissues. Metabolism, including enzymatic reactions. Excretion, removal of the drug or end products, metabolites, from the body. Pharmacokinetic drug interactions occur when one drug alters the absorption, the distribution, the metabolism, or the excretion of another drug. PK drug interactions can be beneficial or harmful. So the first area we're going to look at is when it will reduce the absorption. So we remember learning about chelation. Chelation occurs when a drug binds to polyvalent cations. For example, magnesium, calcium, iron, and another compound. So for example, antacids or iron supplements. The chelated complex cannot dissolve in the gut fluid and then will pass out of the stool. For example, a quinolone antibiotic binds to calcium-containing drugs and dairy products. So So if taken together, the antibiotic will not dissolve, it won't be absorbed, and the infection may not be adequately treated. Drugs with polyvalent cations or other binding properties, for example, antacids, multivitamins, sucralfate, bile acid resins, aluminum, calcium, iron, magnesium, zinc, phosphate binders, these should be separated from quinolones, tetracyclines, levothyroxine, and oral bisphosphonates. Some drugs require an acidic gut for adequate absorption. So if the gastrointestinal pH is increased, absorption will be decreased. Example, acid-suppressing drugs like proton pump inhibitors will decrease the absorption of some antifungals like itraconazole if they're taken together. This could result in an untreated or resistant infection. The gastroesophageal reflux disease and peptic ulcer disease chapter will have more of a comprehensive list of the most common drugs that have binding interactions or require an acidic gut for absorption. So let's keep moving. So let's look at induction or inhibition of metabolism. So the majority of the pharmacokinetic drug interactions occur during metabolism. This could be, for example, in the phase 1 or phase 2 reactions that happen in the liver. So the drug-drug interactions could be harmful, they could also be beneficial. An example of a beneficial interaction might be like looking at the HIV meds, ritonavir and darunavir, when they're used together. Ritonavir inhibits the metabolism of darunavir, which ends up boosting darunavir levels, increasing its efficacy in treating HIV. Examples of harmful interactions, we look at clarithromycin. It inhibits warfarin metabolism, which then increases the INR and risk of bleeding. We look at rifampin. It induces warfarin metabolism, which decreases the INR and increases the risk of blood clot. Both reactions are potentially harmful, but treatment with these drug combinations might be necessary. The dose of warfarin can be decreased with clarithromycin. Or it could be increased with rifampin to keep the INR in the desired range. So basically, you have to remember to adjust dosing whenever the metabolism is affected. Okay, so moving on, looking at decreased or increased excretion. All right, so this looks at the kidneys. So renal excretion is the primary route of drug excretion. Drug interactions can block or enhance renal excretion. So here's an example. Example of decreased renal excretion. Probenecid blocks the renal excretion of penicillin. So giving probenecid with penicillin could be beneficial when high penicillin levels are needed to cross the blood-brain barrier and provide effective treatment of neurosyphilis. An example of increased renal excretion. So we're looking at salicylate. So for example, aspirin overdose results in toxicity. So intravenous sodium bicarb alkalinizes the urine, which causes the salicylate to become ionized. Ionized compounds are more hydrophilic, water-loving, and will stay in the urine. Less will be reabsorbed through the renal tubules, for example, across the lipid membrane back into the blood. Compounds that stay in the urine will be renally excreted. All right, so we're moving pharmacokinetics. We're going to go look at enzyme systems, drug metabolism, and drug interactions within the cytochrome p.450 enzyme systems. Okay, so the purpose of cytochrome p.450 enzymes is to catalyze phase 1 reactions that either produce essential compounds, for example, cholesterol and cortisol, or uncover or insert a polar, for example, water-loving group on a compound to facilitate renal excretion. So cytochrome p.450 enzymes are primarily expressed in the liver. So more than 50 cytochrome enzymes have been identified, with 6 of them metabolizing most of the drugs that people take. So cytochrome 3A4 metabolizes 34% of all cytochrome p.450 drug substrates. The function of cytochrome p.450 enzymes can be affected by genetics. In other drugs that act as enzyme inhibitors or inducers. A table of common cytochrome p.450 enzyme substrates, inducers, and inhibitors is provided at the end of this chapter. The next thing we're going to look at is prodrugs. Inactive drugs converted by cytochrome enzymes to active drugs. Prodrugs are taken by the patient in an active form and are converted by cytochrome p.450 enzymes into the active form. Prodrugs are used by drug manufacturers to extend the dosing interval. An example of this is valacyclovir, which is metabolized to the active drug acyclovir. Valacyclovir has higher bioavailability than acyclovir and is dosed less frequently. Prodrugs are used by drug manufacturers also to prevent drug abuse. An example of this would be Vyvanse, which is lisdexamfetamine, which is formulated with an amino acid lysine attached to the amphetamine. This renders the amphetamine inactive until the lysine is detached by enzymatic cleavage, which prevents crushing and snorting of the drug. The study tip gal below will list some common prodrugs and their active metabolites, along with some example safety concerns that can arise when a prodrug is used in patients with altered drug metabolism, for example, due to genetics or a drug interaction. So let's take a look here. So there's a chart listing off some different examples. Within the chart, we can see things like valganciclovir, and that's the prodrug for ganciclovir. Valacyclovir, prodrug for acyclovir. Primidone is the prodrug for phenobarbital. Let's see. Levodopa is the prodrug for dopamine. Fosphenytoin is the prodrug for phenytoin. Cortisone is the prodrug for cortisol. Codeine is the prodrug for morphine. Capecitabine is the prodrug for fluorouracil. And then let's read some of the example safety considerations that are in the chart here. So codeine by itself and in combination products such as in Tylenol number 3. Risk of toxicity with ultra-rapid metabolizers of cytochrome 2D6 due to a more rapid conversion to morphine. Do not use in the ultra-rapid metabolizers of 2D6 risk of poor analgesia with poor metabolizers of cytochrome 2d6. Use an alternative analgesic in patients identified as poor metabolizers of 2d6. So that's good information. Then we're also looking at clopidogrel, Plavix. So risk of cytochrome 2C19 inhibitors, which can block conversion to the active form of the medication. So do not use with cytochrome 2C19 inhibitors, including omeprazole and esomeprazole, because it can decrease the antiplatelet effects. Risk with poor metabolizers of cytochrome 2C19 or low conversion to the active form with reduced antiplatelet activity. Use an alternative 2C P2Y12 inhibitor in patients identified as poor metabolizers of 2C19. So that's good information. So non-cytochrome p.53 enzymes. So cytochrome p.53 enzymes are involved in phase 1 reactions. Other enzymes, including those active in phase 2 reactions, can also alter drug levels. For example, bictegravir, an antiretroviral drug for HIV, is a substrate for cytochrome 3A4. And the phase 2 enzyme uridine diphosphate glucuronidase transferase, UGT 1A1, inducers or inhibitors of cytochrome 3A4 or UGT 1A1 will change the metabolism of bictegravir. Another type of phase 2 enzyme, N-acetyltransferase, NAT, is well known due to its identification early in the history of pharmacogenomic studies. NATs are highly polymorphic. Differences in the degree of isoniazid toxicity were found to be due to differences in the rate of acetylation by NAT. Alright, so let's take a look at our timer. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Alright, we have about 10 pages left, so we'll pause here. This will be part 1 of chapter 3. Then we'll do part 2.